No. I'm very delighted to introduce our next speaker, who's Dr. Haesun Choi. She's a professor of radiology at the MD Anderson Cancer Center. I think we're all aware that size measurements are inadequate to evaluate drug response to these targeted therapies, and Dr. Choi has pioneered a modified method for evaluating drug response, which incorporates tumor density and size measurements. It's called the Choi criteria. And so she's here to speak to us about lessons learned from GIST.
Well, thank you. And then it's really great to see y'all. I was saying just a few minutes ago that it's a larger number of people turned out to be here than I've seen in the physicians group. So it's great. Okay, today I was going to introduce some new concept of response evaluation of a solid tumor based on what we've learned with the stromal tumor evaluations. And in a solid tumor, when the tumor responds to the ongoing treatments, and typically the size of mass decreases over time, as you can see here, in the first two pre-treatment evaluation to 7 months, it gradually decreases. Now, either we use a SWOT criteria. There are several criteria that we currently use in a response evaluation. The SWOT criteria is one of them, and based on the two-dimensional measurements and the RECIST, the so-called response evaluation criteria in solid tumors uses one-dimensional measurements. Either one of them, these two are the most commonly used nowadays, either one of them, the response evaluation of a solid tumor is based on changes of tumor size. Now we have a new version of RECIST, so-called RECIST version 1.1. This is just published early this year. And they made a minor revision in the definition of a progression of disease, and they now allow to use FDG PET to confirm the response. But basically, they stayed the same as far as measuring the unidimensional the measurements to evaluate the responses based on size changes. So now let's look at this case. This is a case we actually had more than 10 years ago, the renal cell carcinoma. And he was on the thalidomide trial back then. And there's a pre-treatment CT and the post-treatment at 4 months after. As you can see, the tumor looks kind of similar in an overall shape, the size. But you can also see it's obviously different. And all these little dot cells and are no longer there, and the tumor became a lot cleaner. So what does that mean? And we're supposed to tell them, and then the reading room, and the radiologist is supposed to advise them as tumor is responding or not. And back then we kind of thought that this tumor is responding, although the patient got off the trial because based on size criteria that considered to be not responding. Okay, that was over 10 years ago. Now we see those findings, those features more and more recently, particularly those who are undergoing this new targeted therapy, including imatinib on the Sutens and the Avastin and those group of treatments. There are two patients, I put it here. One is renal cell carcinoma, who's on the Suten treatments in the pre and post-treatment 2 months after. And you can see the tumor is still there and very similar, except the subtle changes inside is no longer there. And the colon cancer been on an Avastin, which is anti-angiogenic drug, and 2 months after, they're very much different, but they're all there. So these tumors, the big question is that are these responding? Now let's look at our experience of the stromal tumor. Now, again, this is the same slide I showed earlier. This is a recurrent stromal tumor in the peritoneum who had a small bowel cyst at a pre-treatment study. As in any other solid tumor, typically they do decrease in size. However, not all like that. Actually, more often, this is what happens. And the tumor looks very similar in an overall configuration. There's a liver mets from the stromal tumor. And if you look at you have these these are enhancing and solid component within the tumor. It's gone, almost gone in every single of these. And then also you can see these little distals, and those are tumor vessels. You can see quite often in just routine CTs. If you do triphasic, so-called arterial phase images, you may see, you will see a lot more. But you can see this because this tumor is a very, very vascular tumor. And so those vessels disappear, and whatever it's enhancing, solid compartment disappear, and it changes, the big tumor becomes very homogeneous, and we call the hypotenuating, the density decreases. So white tumor become black. So higher density become low density. This is a typical of responding stromal tumor when it was treated with the targeted therapy, such as an imatinib. Okay, I put a few more examples here of 2 slides are patient with the peritoneal and the liver metastasis. So you can see the similar findings, especially if you look at back here, these 2 tumors look the same in size, similar in size, but it changed dramatically inside of the tumor. The tumor behavior is that what we're looking at. And that's the same here. And this is a gastric cyst. It changed the density. The overall configuration is still there, and we can't not even measure if somebody asked me to measure this tumor. Now, this change, we actually now able to see this as early as 5 days after the beginning of the treatment. So you can see that this chunk of solid component within the tumor starts to disappear. Okay, these are all typical of responding GIST. Now, some GIST actually grow despite there is clinical and PET responses. And like this patient, the tumor, if you measure the tumor size only, and you have to call the tumor is growing, it's progressing. Measure the density, it drops a little bit. So back then, this is one of our earliest patients, so we had to prove that this is not really progressing. So we had a PET CT, and the clinically patient was a lot better. Okay. So there's another patient, the liver mets, and one of these lesions, and it's getting bigger and eventually getting smaller, but then you can see the changes in density. And there's another tumor here, it's continuously growing, but density drops. These are responding tumors. Okay. Based on this observation, we decided to look at the entire, about 40 patients we reviewed the CT images and the PET images and see how they look like and when they respond. So we had a total of 173 lesions, and PET images were evaluated based on EORTC criteria back then, and then CT was evaluated based on 3 parameters, and the change in tumor size, and then we measured the tumor density with the unit of so-called Hounsfield unit. Then the tumor density can be easily measured by just put your computer, the cursor, region of interest, and then the computer just automatically give you the numbers. And then third parameter that we called overall tumor status. Overall tumor status is just simply the subjective observation, based on subjective observation by using radiologist bare eyes and we're looking into entire characteristic of the tumor, not only in addition to tumor size. We're looking at the changes in tumor vessels, like all these little white distals, and then the changes in the solid components, and the changes in an overall tumor density in addition of tumor size. And then we named that overall tumor status. So we compared the changes in overall tumor status. That is purely based on radiologist bare eyes. That's what we do in the reading room. We don't particularly measure to provide 30%, 50%. We try to evaluate the entire disease and based on multiple lesions in the body. So we compared the changes in overall tumor status and the changes in SUV max measured on PET images. So grade 1 on this column, on the horizontal column, grade 1 is progression of disease, and 4 being the best response to is a stable disease. And on this side, grade 1 is